20 minutes. And then I'll have 5 minutes to quickly finish up, and then hopefully 5 minutes for questions, because I can ramble. And my friends there can assure you. So it's just a pleasure to be here. I'm from DeKalb, so class of '84. Cindy Crawford was our valedictorian. You know, I used to ride my skateboard all over this campus, sneak into every gym to shoot hoops. So DeKalb is you know, very, very dear to me. And Gerald, this whole CRP thing with NIU, count me in. Any help you need from a medical perspective, that would be just amazing.
Here, here.
So, I was an ER doctor for many years, 23 years at Downlarge in Geneva. And about a decade ago, I became interested in addiction medicine as, you know, the patients we were seeing, you know, more alcohol use disorder, more opioid overdoses and so forth. And I started to study it, started to do a little bit of outpatient work around opioid use disorder, and basically just kind of fell in love with it. It was just like, where has this been? I mean, these patients get better. All you gotta do is treat them. They're fantastic patients. So it took me a few years to sort of extricate myself from the ER, but now I'm doing just addiction medicine in that ER. But so I work in residential, outpatient, I do a lot of telemedicine. I just took a job with the DuPage County Health Department. So I'm spread way too freaking thin, but I love it. I love every bit of it. So, but at the end of the day, I feel like I'm well positioned to sort of help emergency departments get better. I know the ED, I speak ED, I know, I mean, working in ED is very challenging, and then to put something on top of their already difficult day, I have an appreciation for it, but that's what I hope to do, is really kind of elevate the care within the ED for patients suffering from primarily opioid use disorder. So let's dive into it. So really, I'm only asking these EDs to do 3 things. Number 1, dispense take-home naloxone. Not prescribe, but dispense. Number 2, initiate buprenorphine and give a bridge prescription until outpatient follow-up can occur. And I've got methadone in parentheses there because you probably are aware that the methadone rules are about to kind of change and be liberalized. So I think really progressive hospitals and clinics you're gonna see methadone a little bit more frequently in situations that are not quite so regulated as they are now. And then finally connect to a community provider or provide a warm handoff. Not just, here's a list of phone numbers, call on Monday. You know, that's what we did for years. I mean, what I used to do, non-fatal overdose comes into the ED, we watch it for 2 hours, because the half-life of naloxone is about an hour, so 2 hours if the patient's awake and breathing, they're good. They're not gonna go back down. Here you go, here's some phone numbers. It's just not enough. So we really need to organize, get a system in place where there's a warm handoff, which means, you know, not only can you be seen at this clinic within the next 72 hours, our case manager, our social worker, our peer is gonna make sure your ass is in clinic. And then if the clinic, you don't show, someone at the clinic is going, hey, I got a fax that this guy OD'd on Sunday, where the hell is he? And then so it's just gotta be that kind of connection. So, but all of these things are not hard. All of these 3 things, they're not hard. And in the emergency department, we do a lot of things that are hard. Like, you know, if somebody comes in with signs or symptoms of a stroke, we have to have the CAT scan done and read in 30 minutes. That's hard. If someone comes in with a heart attack, we have to have the cardiologist open up the vessel within 90 minutes. If someone comes in with sepsis, we have to have antibiotics fluids in 3 hours. Those are hard things. You know, it's like pressure, pressure, pressure. None of these are hard. So, you know, and those other things I talked about, you know, if you don't get your heart attack treated in 90 minutes, you may lose your certification to be a chest pain center. If you don't get the CT scan back in 30 minutes, you may lose your certification as a stroke center. We need something like that to make sure we do a fucking better job for opioid use disorder. So, real quick, most of you probably know how buprenorphine works. I'm a big fan, you know. It's a medication that it's a what we call a partial agonist at the mu opioid receptor. So it doesn't fully stimulate the receptor, but it stimulates the receptor enough to take care of withdrawal and cravings. And interestingly, even though it doesn't fully stimulate the receptor, it blocks the receptor. It's got a very high affinity for the receptor. So then other opioids can't attach to the receptor. And then the third thing that makes it so nice is that it's got a long half-life. It sticks around a long time. I mean, it's a miracle drug, you guys. It's super safe, super effective, and the blue line is buprenorphine. So it's got this what we call the ceiling effect. So you can't overdose on it. Like if you took 10 of them, like, oh, I'm going to get high, you took 10 of them, you're not. It just levels out. Regardless of the dose, your opioid effect stays the same. So very effective medication. And this is really what opioid agonist therapy does. You may have seen this slide before. So, you know, it's really kind of all about dopamine as the final common pathway in addictions, opioids being no different. So we live in sort of the blue range of dopamine. You know, if something great happens, we get an A on a test, we get a little bump in dopamine. You know, we have a great dinner, get a little bump in dopamine. But we stay in the blue range. We start to use opioids, you can see the dopamine goes high into the euphoria, pain relief, all those effects. But then it falls down, but you're still in the normal range. But at some point, if you keep using illicit opioids, exogenous opioids, the downregulation of the receptors, etc., sort of shuts off that dopamine sort of pathway, and now you need more exogenous opioids just to get a little bit of dopamine. So then all of a sudden you're down here in withdrawal territory, and you're miserable. You can't take care of the kids, you can't go to work. So now you're using exogenous opioids just to get back to the normal. So what happens with opioid agonist therapy, buprenorphine or methadone, is it just gets you back to the blue. It just gets you back to the blue. And it's very important to be in the blue because it's very difficult to do the things necessary for recovery when you're in the red. You know, I mean, I'm all down with CBT, DBT, yoga, mindfulness, journaling, but you know, it's hard to do all that shit when you're in the red. So this gets you to the blue, your dopamine levels are stable, and you can get on with life and do all the other things that are necessary for recovery.
You're giving them a...
So, oops, I want to go back. Okay, so here, just a couple quick clips of patients of mine. Oops.
You're giving them a gift. Like, maybe they won't make the right decision, but if they're like me, like I said, the first time I took it, I don't remember if it was like right away that I got on this path. But in the back of my mind, I always knew that it was there. And then the second I was ready, like I found a doctor. I mean, I made it happen. So why wouldn't they want to give that option to, you know, any other patient that comes to the ER?
Yeah, I love that. You're giving them a gift. And she's super stable. Saw her a few weeks ago. She was pissed at her son because he broke a $400 hockey stick and was laughing about it. So she's doing real ass parenting now. Got her kids back. You know, spending $100 on a hockey stick.
You're giving them a gift.
Yep.
Like, maybe.
There we go. One more.
I'm 51 and I started when I was 12, and this is the easiest time that I have ever had in my life trying to stay clean and sober, ever. And that's a very big deal.
Yeah. So she's doing it too. There for her grandkids. Okay, so I'm here to tell you that the main treatment for opioid use disorder is medication. Y'all want to fight me? I'm here all day. The main treatment for opioid use disorder is medication. And I'll try to prove that to you. because we have a lot of data. It decreases illicit opioid use, keeps patients in treatment, reduces mortality by 50%, maybe even a smidge more. I mean, no medicine we have in decreases mortality like that. It's unbelievable. Decreases HIV, hepatitis C, criminal activity, healthcare costs, and it is on the list of World Health Organization's essential medications. Okay. This is a new study that just came out in January. This is really something. So, receipt of opioid use disorder treatment prior to fatal overdoses in Connecticut. So what these authors did is they looked at the patients that died of opioid overdose in Connecticut. There were almost 1,000 of them. They were able to determine if about 250 of them had prior treatment some sort of treatment in the prior 6 months. And what they found is really meaningful and striking, that the patients that had no treatment did a little bit better, or at least trending to doing a little bit better than the patients that had treatment, but treatment that didn't include buprenorphine or methadone. So treatment that included non-MOUD was worse than no treatment at all. You got me? So why do you think that? Why would that be? Why would that be? It's the same reason why you're at such high risk leaving jail. So you're in a 30-day program, you get through acute withdrawal, you're learning, relapse prevention, you're learning CBT, you're journaling, your anxiety's better. The whole time you're doing that work, you're losing your tolerance. You're losing your tolerance, your dopamine circuits are getting healthier, your downregulation of dopamine receptors and opioid receptors is turning back on. So now you've got more receptors. You leave, you slip, and you've lost your tolerance and you die. So, this is what they found. So, just a couple quotes from this study. So they write, in fact, it seems likely, based on our estimates of the number of people with opioid use disorder not exposed to treatment, that non-MOUD treatments were inferior to no treatment. Interestingly, even exposure to methadone or buprenorphine seems to be protective. Like those patients that even took it for a little while didn't necessarily, again, there are some complicated statistics in this study that I can't really understand, but just exposure to those medications is somewhat protective. And here's the killer. This is the last paragraph, or most of it. I tried to cut out as much as I could, but the findings in this report can inform individuals with opioid use disorder and their loved ones regarding treatment exposure choices. Furthermore, the findings can be considered by state agencies and organizations involved in the regulation of OUD treatment facilities, including those involved with payment and quality. This will become increasingly important as states make decisions on spending opioid settlement funds. We are hopeful that our analysis will inform decisions that will decrease the number of opioid overdoses nationally. So that's nice, scientific paper speak. I'm going to translate it for you. If you hold yourself out to treat opioid use disorder and don't provide or some mechanism by which the patient can get buprenorphine or methadone, you're doing it wrong. And you are not going to get paid, and the regulatory bodies are not going to approve you. That's the future. You can't treat opioid use disorder or hold yourself out to treat opioid use disorder without these medications. Mortality 50%, you guys. It's just, you can't do it without it. Again, I love all the other stuff. So, and we know this is very deadly. This is a famous study from 6 or 8 years ago, looking at mortality in the year after going to the emergency department with a non-fatal overdose. This is Massachusetts data. You know, Massachusetts has a robust treatment landscape, but what they found is in these 4 years, there were about 17,000 patients that went to the ED. After 1 year, 5.5% of them had died. And that's about the same mortality as a heart attack. I mean, and these patients are younger, healthier. And furthermore, out of that 635 patients that died, they're kind of front-loaded. 20% of those died within the first month after that ER visit. Furthermore, 20% of that died in the first 2 days. So those patients that are in your ER, having survived a non-fatal overdose, are really not doing well and really at risk for death, even in the next few days. And we need to be aware of that, and we need to do better. It's a chance to intervene. Oh, and 67% of those died of overdose. Because, as you know, people with opioid use disorder die of other things. 2/3 of them died of overdose, the rest, suicide, trauma, infections, etc. This is that same data, but it's looking just at those 30 days, not the whole year. And look at that spike just, the day after the ER visit. Very vulnerable time. So, we need to do it. Everybody knows we need to do it. This is an editorial from the Annals of Emergency Medicine. This is Dr. Jerome Adams and Dr. Deborah Oury. If you remember, Jerome Adams was the Surgeon General under the Trump administration. He was actually pretty good on this issue. Has a brother that struggled with substance use disorder for years. So they wrote in our journal, the emergency physicians have been and always will be the all too necessary safety net for many. An important partner in combating the opioid epidemic, can't be complacent. Our patients and communities need emergency physicians to redouble their efforts, challenge their colleagues and institutions to do more, now more than ever. This was July of 2019. And of course, just 6 months later, we had the COVID, and so we lost a few years, and not only did we lose a few years, the emergency departments were just, they did Herculean work, and they're hurting. They're hurting. So we should be aware of that, and it's not lost on me that I'm asking them to do even more. So 3 years ago now, this came out, the consensus recommendations on the treatment of opioid use disorder within the ED. So this is from the American College of Emergency Physicians. When this came out 3 years ago, I thought, oh, awesome, finally. All we have to do is make a bunch of copies of this, PDF, send it to my friends, and it's gonna happen. Well, it doesn't work that way. It really has to happen kind of at an institutional level, but this document really does help sort of convince people that, hey, it's not that hard, here are the recommendations of your college. So, but again, this has been 3 years. Finally, 2.5 years ago, March of 2022, the state of Illinois came out with the SOAP, the State Overdose Action Plan. Great document, 25 priorities around access and equity, criminal justice populations, harm reduction, really, really good stuff. And priority number 10, increase initiation of buprenorphine in emergency departments for people that present with overdoses and withdrawal. So, I mean, that's 2.5 years ago, and the state really hasn't done much. And Director Garcia, I don't think is here. This is awkward. We need work in this area. We need work. We need work in this area. Let's do it. So, here are the things. When I talk to ER colleagues that are not really excited about this population or this work, 10 minutes left, okay? I would say, listen, it saves lives, decreases length of stay. You can get them out of the ER longer, they stop puking, cost effective, that's been shown, increasing patient and staff satisfaction, decreases stigma, because you start to see these patients get better before your eyes, and they're grateful, and that sort of diffuses throughout the department. But if it's not enough, we're going to get sued if we don't do it. This is about 3 years old too. Pretty provocative title, but long story short, in the not too distant future, to not do this is gonna set yourself up for liability. You know, same guy comes with a non-fatal overdose 3 times in a month, and you haven't given take-home naloxone, you haven't even offered buprenorphine, you haven't done, you know, a decent warm handoff attempt. I think most people would agree there's some liability there. So, how have we been doing? This is just real quick. These came out in 2022, 2 studies that I don't think are going to be surprising. So this is after you have a non-fatal overdose, how many of those patients get naloxone and get buprenorphine? It's not good. So about 7.5 patients get naloxone, about 8.5 got buprenorphine. This is 2022. Most of the data comes from like 2019 to 2021. Here's another one. They were able to determine how many prescriptions for bup were given by ER docs, and the question was how many of those prescriptions had another prescription within 30 days after that. And it was about 28.5%. So not zero. And when I look at this, I'm like, well, it could be worse. But if you look at where these prescriptions were written, they were basically all in urban areas where you would expect there to be a decent infrastructure for treatment. And I think the number being that low speaks to the lack of good warm handoff. You know, it's just like the ER doc does the right thing, gets the script, but there's not that good warm handoff. So this basically says there's strong proof of concept within clinical trials, but we need to do better. Okay. Director Garcia did talk about Marnow. Marnow is a game changer. I mean, Illinois is doing some things really, really well. Marnow is one of them. Here's the number. I'm one of the people taking those calls. It works. It really does. You can get somebody on buprenorphine right away, 24/7. She talked about the doc. It's easy. You can just go online. If you're a hospital or organization, you click, you fill out a little survey monkey, and then you can get free naloxone. There, that's the extent of my PowerPoint skills. Okay, just a couple other things that I'm involved with. This is the naloxone project. This is a new. We've been in Illinois. It's been about 6 months. We've been having meetings. We've got about 20 people on a committee. Not for profit. We have no money. It's all volunteer. But basically, the goal of the naloxone project is to make sure that every hospital, kind of starting with emergency departments, are dispensing naloxone to people at risk for overdose. So again, we've got the tools, but it's just so what we will provide to a hospital, and we're right at the point where we're accepting hospitals. Like hit us up, we will help you do this. It's basically, here's how you sign up for a doc. Here's how you order naloxone for free. Here's how you submit data back to the state, and that's it. But we'll just help you do that. And so that's the email. Like if any hospital wants it, Illinois@naloxoneproject.com. So, and we hope to get some funding to actually be a little bit quicker. So, Sauk Valley, I Googled Sauk Valley and this is what came up. So I'm calling you guys out. So these are the counties, at least that were up on the Sauk Valley Community College website, and these are the hospitals, small hospitals, but you know, in areas where a lot of drugs, a lot of overdoses. So Rochelle, KSB, Morrison, CGH. I did a Marnow call yesterday from a woman in Sterling. 5 minutes, I got you. Overdosed last year in Sterling. Taken to CGH, and I always ask this, you know, question. I'm like, oh really? did they give you naloxone? Did they offer naloxone? Did they give you buprenorphine? Did they offer buprenorphine? I've never had a yes. I've never had a yes. So, tragic, but we need to start getting these yeses. FHN in Freeport, Princeton. So, you know, if the Ross, I mean, I know, you know everybody. Like, we need to know these hospitals need to be dispensing naloxone and writing buprenorphine. So we'll help them with the naloxone. If they're like, oh, I've never written buprenorphine, just give the patient the phone and have them call them or not. It really is that easy. It really is that easy. And then we'll teach you later on how easy it is to prescribe buprenorphine. All right, finally, Director Garcia also mentioned this. This is another thing I'm kind of peripherally involved in. So this is the criminal justice, county jails, giving buprenorphine. It's really a nice project. Similar projects should be done in the years, frankly. But if you can see, as she mentioned, there are 26 counties that are part of this learning collaborative. The red ones are part of the Sauk Valley. So if anybody out there knows any people at their jail, sheriffs that run the jail, you know, they just got funding to accept 10 more counties. So that would put it at 35 counties. Cook County already has their own thing, so they're not part of this collaborative. So they're doing it. They're doing it. And I tell my ER friends, like, the jail's freaking doing it. and you're not doing it in your own ED. So if anybody's interested, that's the email to get hooked up with this program. So it's funded, like the jail gets money to start a program. And it's really working. So I think I did it on time. So this is Ziggy and Rex. I used to have my kids on this last slide, and now you'll be looking at like 320-somethings. It's not nearly as cute. So I would happy to take any questions. This is my email, and if you guys have any questions, again, you know, putting me in touch with emergency departments that want to take this next step would be wonderful. Yes?
Yeah, thanks for your presentation. Any data coming out about the integration of peers, certified peers, recovery coaches into the ERs and how that is impacting the results and the follow-up that we're seeing?
Yeah. I love that question. Thank you very much. Not that I know of it yet.
Okay.
I think it's new, but I love peers in the ED or peers on the floor. I think it is just going to be so powerful to really sort of work on patients' ambivalence about treatment and so forth. So I think that's just a great development.
Thank you.
Yes, I just have two comments. My son was in Lee County Jail and was given Suboxone when he was in there. And also, my husband was in the ER about 3 weeks ago, which we thought maybe he was having a heart attack. He was having some chest pains and that. And the doctor, it turned out not that, but the doctor started asking him what things were going on in his life. And he said he had some stress. And he said, what are you stressful about? And he said, you know, my son uses opioids. And he said, do you have Narcan at home? And we said, no. And he wrote us a prescription for Narcan and sent it home with us.
I love that. Now, what would have been even a smidge better? Put it in your hand, because we do know that a prescription handed to somebody that has opioid use disorder is unlikely to get filled. It's less than 10%. You know, hooray for that, doctor.
So I wanted to mention something that we have going on in Michigan. Actually, we took it from a program out of Boston called Project Assert. So we have folks with lived experience that are in the emergency departments at hospitals. And so when there is an individual that comes in, either overdose or another reason, and there's suspected that there's substance use going on, then the nurses or the docs can put in a consult, and then those individuals with lived experience are going in and they're doing a brief negotiated interview with those folks, getting them connected with whatever those next steps look like, whether that's residential treatment, whether that's outpatient, recovery coaching, whatever that might look like for them in their area.
Yeah. Wonderful. Yeah, we've got that going here. It's just getting started. We've got programs at community colleges to get them certified. And it's, of course, it's effective, but hospital administrators might like it too, in case, you know, whoever's in charge of social workers and case managers will like it. Because we used to call a social worker down to see this patient that needs treatment for substance use disorder. And frankly, they didn't really know much about substance use disorder, and certainly not the local landscape of recovery. The peers did. Peers know exactly what's best fit for this patient. So you're saving social worker time and you're being more effective. It's a no-brainer for peers.
That looks like it's all our question. Oh, wait, Joanne.
My kids won't tell your kids that they've been replaced by someone.
I know.
Thank you, Steve.